This week on Poll Hub, a very different yet special episode, one dedicated to women's health. First, it's a very painful and common condition that often takes years to diagnose. We speak to an OBGYN about endometriosis and why it often goes undiagnosed and the emotionally painful stigma that surrounds it. Then, a glimmer of hope. A growing number of Americans say they or someone they know have turned to fertility treatments, and many Americans say IVF is a good thing. We break down the difference between some commonly used fertility treatments, their success rates, and why some women face barriers to treatment. The so-called egg whisperer joins us. Finally, advocacy through art. In lieu of a fun fact this week, we're joined by a Marist professor to discuss her Project Getaway. This is Poll Hub. Let's get started. And hi, everyone. Welcome to Poll Hub. I'm Mary Griffith.
I'm Cassidy Connors.
And I'm Barbara Carvalho.
Today, we bring you a very special episode of Poll Hub, one that focuses on women's health. And we begin with a discussion of endometriosis. Endometriosis is a chronic gynecological condition that affects an estimated 1 in 10 women and people assigned female at birth here in the United States. However, the condition often goes undiagnosed and symptoms unrecognized. So what accounts for these delayed diagnoses? Why do knowledge gaps exist? And how, once diagnosed, is endometriosis treated? To break it down with us is Dr. Jessica Shepard. She is Chief Medical Officer at HERS and a board-certified OBGYN, specializing in women's health and menopause. Dr. Shepard, welcome.
Thank you so much for having me. How are you?
Doing well, thank you. It's a pleasure to have you here. So let's just start at the very most basic level. What is endometriosis? What are its symptoms? And what are its implications?
You know, endometriosis, I think when we think of the fundamental physiology or pathology behind it, is that it's actually a chronic inflammatory disease of the pelvis. And it is estrogen dependent because estrogen is the hormone that really fuels the tissue, which is an endometrial-like tissue that is outside the uterine cavity. But the hallmark of it is that it creates inflammation and a cycle that then goes towards pain and can inflict a lot of pelvic pain on patients, in addition to a lot of other things, including infertility.
And so according to the American Medical Association, it can take between 4 and 11 years to receive a correct diagnosis. Why is there such a gap?
You know, there's a lot of other disease or conditions that overlap the symptoms of endometriosis. And so many times when women come in with their complaints, conditions, or what's impacting them, a lot of times there are a lot of other conditions that come first as far as this might be that. So for example, if someone has very painful periods because of endometriosis, many times they are treated for dysmenorrhea, which is a common disorder among women. And that just really has to do with painful periods. Now, there's a lot of things that can cause painful periods, but when endometriosis is the underlying cause, it may sometimes be I guess you can say misdiagnosis or delayed diagnosis rather, and really getting to the heart of what is creating all this pain. If there's infertility, if there's bowel changes, if there's urinary changes or pain, endometriosis might be the fundamental reason why, but getting to that as the diagnosis is why we start to see that time variation.
You know, as we were doing some research, and particularly survey research, since we focus a lot on public opinion, and one of the things we did find was that most U.S. women surveyed said that they have heard of endometriosis, but few knew about its symptoms. The 1 in 5 women with symptoms reported waiting more than 4 years to even receive a diagnosis. And a plurality of respondents, 47%, said that their pain was initially dismissed as normal menstrual discomfort. Are we getting to a point where there's more awareness in the medical community that can help women deal with these symptoms?
Yeah, that's a great question. I wanted to address initially first about what you said about pain. And that is such an important part that I wanted to make sure that anyone who's listening understands that pain is very often overlooked when it comes to women, not feeling seen or heard. So this goes across even outside of endometriosis. Anything that really contributes to pain, especially in the pelvis, women often are dismissed when it comes to that. So even from a pain category, you know, that's one thing that we can see where women are not being addressed. And then tapping on endometriosis as the cause of the pain is now another reason why we really need to tune into hearing women more and get addressing them when they say they have pain. Now, going back to endometriosis and the awareness of it, I do think that for as long as I've been an OBGYN, I remember even in my training, endometriosis was not a very big part of what we learned. Not necessarily just what it was pathologically, but now knowing how to treat it and manage it. And so for me, I think I was fortunate enough to do a fellowship in minimally invasive gynecology where I actually saw the outcome of what it was doing to women from a pain perspective, but also from internally from a pelvic perspective. And so I think that's really where I had to lean into understanding the kind of the modalities of what endometriosis could bring to women, but also how to treat it and manage it, which is very difficult. I will say that it's not very easy when we think of what are the options, the treatment, the management, the consistency and follow up that's needed for these women. So I do think that we are starting to see more, even on the healthcare front, of being more aware of what endometriosis is, all of the different ways that it can impact women, not just with pain, but infertility. It can impact bowel and bladder symptoms. And then for patients, I think what we have seen in the last 10 years is much more advocacy for patients to be aware of, I need to advocate for myself and go talk to my doctor and also bring up endometriosis as a possibility of what may be causing this pain and the list of other conditions and symptoms that we discussed.
And I think also some of the celebrities who have come forward who have had the condition, I'm thinking of Chrissy Teigen or Bindi Irwin, who have been, very, very vocal and have chronicled their experiences, I think goes a long way to that awareness. But I want to just go back for a second when you talked about treatment, because I think part of, I don't know whether it's fact or myth, but it is very difficult to treat. And what are some of the things that women can think about in terms of managing this condition?
Yeah, I think that that's actually important for women to understand the options in management and treatment, because many times they come into the scenario of hearing their diagnosis or understanding their diagnosis and really being hopeless and destitute because they feel there are no options. And so I wanted to hopefully give some hope to women who might be listening that there are options when it comes to management. Now, granted, I will say that finding the right provider who knows all of the different options sometimes may be a little required in advocating for yourself to find that provider who's going to do that. But when we look at treatments, one of the things that we fundamentally have used for decades now, obviously, is oral contraceptives, which actually have proven to work to some degree in the way that they work in decreasing pain, whether that's decreasing the amount of cycles that you have, which decreases the pain, or again, is helping with decreasing estrogen release, which is again creating that chronic inflammatory and pain. It can work. Now, does it work for everyone? No. Or does everyone want to necessarily take that as their course of action when it comes to management? No. But is it still an option? Absolutely. And I think that there are some people who are managed very well with their symptoms on oral contraceptives. And then also another form of contraception that can work also is an intrauterine device, such as the IUD, or, the other name for it is the IUD, that also too can help women when it comes to, again, decreasing that ratio of estrogen that's released, and also for creating help with pain profiles and decreasing that. So that's kind of in the contraceptive category. Now, we also have the goal of most management and treatments is to decrease that level of estrogen, to decrease the inflammation, which then causes the pain. So another modality is, I'm really glad to have been fortunate to see over the course of 20 years that I've been doing this, that now research has been done that there are medications that specifically are for women who have endometriosis. And some of those medications include a GnRH and antagonist. Now, we used to use GnRH agonists in the back, such as Lupron, but those really had some really, severe ramifications or side effects with women putting them into menopause, kind of medical menopause, which they could be reversed once they're off of that medication. But now even furthering research, which I want to give props to science and research, and taking that time and effort and money to find a medication that is going to help women who have endometriosis pain. So that's your GnRH antagonists, which again are decreasing estrogen release. We have some ones from the past that we've used, such as danazol, which is a testosterone derivative, which is helpful in helping, again, that ratio of estrogen. And then we have surgical management. Surgical management is really where, I spent a good 15 years in high volume surgery in helping women who have endometriosis, and then now looking for the actual tissue removal of endometriosis from the pelvis. We've seen it on bowel. I've seen it on bladder. I've seen it on the diaphragm. I've seen it on lungs. And this
Oh my goodness.
all over the place. Anywhere where endometrial tissue can go and cause pain, it will go. And so I think that, again, looking at it from a surgical perspective, we have good data that shows that it really helps with decreasing pain profiles for as much as 5 years after a surgery. Again, for the type of surgeon who's specialized in removing that tissue. So there's a really wide scope of how we can help women throughout this, and that women should not feel hopeless when entering the conversation of management of endometriosis.
So it can't be cured. It also can't be prevented. So when we're thinking about the ramifications, obviously one is the physiological aspect of infertility, but there's also that emotional dimension associated with it as well. But because there's this delay oftentimes in diagnosis and in treatment, can early detection and early treatment help a woman's chances of becoming pregnant?
Yeah, that's a great question. I think what we have seen in the past is there like magic imaging that would be able to be done that might be able to help women, have more of a predictive type of value to help them see what are my chances, or if I am, have a genetic predisposition to having endometriosis, where am I in that stage? Now, we haven't found that because we haven't really found that endometrial implants are the best to be visible on imaging. Typically, when we use imaging, specifically MRI or ultrasound, is that the lesions really have to be substantial, or they have to have a very large cyst on the ovary, which we call an endometrioma, that we can say, you know what, this person most likely has endometriosis. So when we look at the broad range of women that have endometriosis, most of them wouldn't fall in that category of having something so severe that we would see it on imaging. So this is where we started to see kind of a little bit more enthusiasm towards blood work, right, in a lab kind of detection value. And I think that's where we're seeing more promise, is saying what lab value or what lab test could be developed that we would actually be able to see if someone has endometriosis, or you want to look at sensitivity and specificity. One, if they have it, but also maybe on a level of severity based on a lab. What does that mean for someone who has endometriosis, and what stage, I guess you could say, do they have based on a lab value? Now, we have had some promising things. I think that there are some blood tests that are out there right now that have biomarkers that can be used with clinical data as well, right? So what is the patient having as far as symptoms to help diagnose the condition and aim towards reducing that diagnostic delay. So I find I'm much more optimistic in that, kind of area as far as labs being able to help you diagnose endometriosis, because this is, again, something that could be used globally. It could be used for every woman. And that's where I think we're going to see more of the value of being early diagnosis and prevention, because with any disease, that's the best way to get better outcomes, is having those two things.
Doctor, before I let Barb have the last question, I did want to ask you, there seems to be this stigma associated with pelvic pain and menstrual discomfort. And when I read the statistic that 60% of respondents, according to a Healthy Woman AbbVie survey, said that they don't discuss these conditions because of that stigma, it almost baffled me. Why is there such a stigma associated with these types of symptoms? And how can women overcome that perception?
Mm-hmm. Yeah, I think, two things that come to mind as you bring up that question is kind of embarrassment and shame with anything that has to do with below the belt issues. And I think that has gone, for centuries now, for women specifically, is that there's this expectation that everything needs to be perfect there and outcomes need to be perfect for women when it comes to the pelvis. And a lot of that is rooted in fundamentals of reproduction. Right. So the value of a woman, and this is where I kind of get on my soapbox about patriarchy, is the value of a woman is based on reproduction. And so if something is going to decrease that ability for a woman to do that, then that's where we get these labels or the ability for a woman to feel shame when there is something that's wrong with the reproductive system. And so I think that there's a lot that comes in societal expectations, and we really have to bring the conversation there, or else we're really not addressing endometriosis in its full scope of what it brings to women on the emotional side. And I think that's an important part that needs to continue in the conversation, if not be heightened.
Along those lines, many women do feel it's difficult to advocate for themselves. They advocate for their family, they advocate for their children, they advocate for their parents, but they're willing to endure a lot of discomfort with regard to themselves. What advice would you give to women? In a particular survey, 72% of respondents, this is the Healthy Women Survey, said that they had to see 2 or more healthcare providers before getting diagnosed. So this is not easy. You may start out with, your primary physician and be able to explain your symptoms, but you don't necessarily get the care that you need. So what are a couple of things that women can do just in terms of advocating for themselves?
I think advocacy is one of the best things that we can do for ourselves, but it's sometimes one of the hardest things that we can learn how to do for ourselves. And so in advocacy requires, I think, community in order to help support the fact that you're going to advocate for yourself, because that's not something that we're actually taught. How do you advocate for yourself? And like you said, we advocate for a lot of other people, but when it comes to ourselves, we a lot of times will become a little bit falling into the shadows of that. So I think one, it needs to be part of education, but I also think it needs to be taught. We have to be taught how to advocate for ourselves. And I think that is what comes through community and discussion, such as the one that we're having today, is bringing it to the forefront, but also giving the steps in how to do that, because many people feel lost when it comes to advocating for themselves.
Well, we're going to leave it there today, but Dr. Jessica Shepard, Chief Medical Officer at HERS, we thank you so much for such an informative conversation today.
Thank you so much.
Infertility affects many families in the United States, making no exception for income, education, or race. It's estimated that about 1 in 6 adults experience infertility, and 1 in 8 women of reproductive age report they or their partner required fertility services. To illustrate what these numbers mean, according to a 2023 Pew Research Center survey, about 4 in 10 adults, that's 42%, say they have used fertility treatments or personally know someone who has. And that's up from 33% in 2018. About half of white adults, 48%, say the same, compared with 37% in 2018. As fertility treatments have made great strides, particularly with regard to IVF or in vitro fertilization, major barriers do remain, most significantly access limited by income, lack of insurance coverage, and, of course, high costs of the procedure. Joining us to discuss assisted reproductive treatment, and specifically the option of IVF, is Dr. Amy Avazadeh. Thanks so much for joining us today, Amy.
Thank you so much for having me on, Barbara.
I want to tell our audience a little bit about you. Dr. Amy is a reproductive endocrinologist and fertility specialist, widely known as the Egg Whisperer. Dr. Amy is the founder of the Egg Whisperer practice and a nationally recognized expert in IVF, fertility testing, and egg freezing. She's also a leading advocate for fertility education and access to care. So hopefully we're going to be doing a little bit of that today. Within this decade, we'll actually mark the 50th anniversary of the birth of Louise Brown, who in 1978 was known as the first test tube baby. Since that time, there have been just astonishing advancements in reproductive medicine. So what exactly is IVF, and how has that changed the infertility journey for many couples?
Yeah, so IVF is basically a process where a woman takes fertility drugs to stimulate her ovaries to grow eggs. We extract the eggs in a procedure called an egg retrieval, and then we put eggs and sperm together and we make embryos, and then we can deliver them to the uterus in a procedure called an embryo transfer, or we can save them for the future. Some people do IVF to preserve their fertility. And they do that because of, what they want to do in their life first before they have babies. And we put them in later. And that procedure is called a frozen embryo transfer. IVF has, I think, revolutionized things for many people. It's given them the opportunity to have babies when they may not have ever been able to have babies. IVF was first invented for women who have blocked fallopian tubes. So before IVF, if you had blocked fallopian tubes, you could not have a baby with your own eggs. Also for men who have really low sperm counts, ICSI was invented for that purpose, to take a single sperm and inject it into the egg. And that has also really changed things for people who have that problem, for them to be able to have babies now.
Now, this isn't, you've talked about a number of steps that are part of this process. It's not an easy road. And I know that research also points to the need for a number of IVF cycles to increase the likelihood of success. What kind of an emotional toll does this take on those undertaking the process? And what kind of challenges should couples prepare for?
Yeah, I like to say that IVF is very fun, but it actually isn't. It can be very frightening. It can be very frustrating. And I think the most important thing for people who are starting their journey is to understand the emotional toll that it does take. And one of the things that I tell people is the biggest risk of going through IVF is depression, anxiety, and PTSD and trauma. And people need to realize that up front, so that they're well informed about that and that they take really good care of their mental health. I have a mnemonic, it's called Fertility Team. And I tell people to build their team from the beginning, not after cycles that don't work. Therapy, exercise, acupuncture, looking at their fertility nutrition, find a meditation practice that they can follow. I think those things are really important from the beginning, at the start of your IVF journey. And know your why. Know why you're doing IVF. Know what your prognosis is. Know upfront how many cycles it might take for you to have the family size that you want, so that you go in with the right set of expectations. And I have had a patient very recently, 40, she had one healthy embryo. She came to me, she was very disappointed. And I said, this was an A+ cycle. To get a high quality euploid embryo, which means chromosomally normal, 1 at 40 is amazing. It can take 6 cycles to get that one. But she was disappointed. She was distraught. She was depressed. But if she had the right set of expectations going in, she would have felt like a winner, not defeated and like a failure.
So I think it's very important that people build a support group around them to go through this and not be going through this alone, either individually or as a couple. I might add, I had been referencing, couples, but there are singles also that use this procedure and process to build a family as well.
Absolutely. Independent motherhood. I'm a huge fan of that. I have a lot of single moms by choice, which I like to call independent mothers, because single just sounds lonely, but independent sounds very empowering. I have many.
Language is a big, big deal.
It is. Independent fathers as well, men who just haven't found the right partner, but it's really important for them to be dads. So we're seeing a lot of independent fathers as well now, more than I have before.
Dr. Amy, thank you so much for being here. And I know there's a huge financial gap with insurance and everything with IVF, but from your experience, what parts of the process or women's healthcare system create the biggest obstacles beyond just the financial side?
I think access to care. I think there are a lot of, we know about maternity deserts where people can't even see an OBGYN. And in a lot of communities, there are also infertility doctor deserts where there's maybe one practitioner within 2 hours of where you live. And I think that makes access very difficult. Luckily, with telehealth platforms, you can access a doctor who may not be in your town. But I think for people who live in states where there's only one fertility doctor, access is an issue.
Do you find people come from long distances to your practice?
I do. I have probably about 30% of my practice is from out of town, out of state, out of country.
That's quite traumatic. I do want to talk a little bit, though, about the financial costs, because it can be quite prohibitive for many families. I think I also read a statistic that, people are willing to spend about a third of their income to do this. So this is not a small undertaking. Why are the costs so significant?
Well, the cost of the technology is expensive. If you think about the number of people, team members that are involved in your care, their salaries, the overhead of these fertility practices. I mean, the lab that I run is a $3 million lab, and you can imagine how much it takes to actually run the lab. I have 3 PhDs that work in my lab. If you think about their salary, so it's very expensive. And then you have medications. The cost of medication can sometimes be just as expensive as the cost of the treatment itself, if not more. So Americans don't realize that they're being price gouged. You heard that story, I'm sure, about about epinephrine and how that. Do you remember? This is a few years ago where the costs went up. A vial of a medication in the United States that's used in an IVF cycle, and sometimes people need 2 to 6 vials, is about $90 in the United States. You can get it overseas for about $13. The cost of that vial is about $1. So,
Wow.
so we're being terribly taken advantage of when it comes to the cost of the medications. There's no reason why the cost of medications for an IVF cycle should be $8,000 for one cycle, but that's the reality. And when you don't have insurance coverage for that, that can be the reason why someone is not able to do another cycle because of the cost of the medications.
I know the Trump administration last October, I believe, moved forward on trying to reduce the costs of some of the medications. Do you see that that has made a difference, or?
It has not happened yet, but if we can bring some of these medications that are available in Europe and in other countries to the United States, it will tremendously decrease the cost of IVF for Americans.
Doctor, we're talking a lot about IVF, but there are other types of fertility treatments available. So when someone is weighing their fertility options in terms of treatment, what should they keep in mind, and how does IVF differ from other commonly used treatments such as IUI?
Yeah, so when you're thinking about doing other treatments other than IVF, you want to talk about what your diagnosis is, what your prognosis is, and what's the best treatment option for you. And for some patients, IVF is not acceptable to them for religious reasons or ethical reasons. So when I work with a patient, I'm always asking them, what are your beliefs? What are your goals? And what are you willing to do? And then I design a protocol and plan for them individually so that I can give them the best chance of pregnancy the way they feel most comfortable with. But what I find sometimes happens is people think that you have to do things in baby steps. Like first you have to do 3 to 6 cycles of IUI, and then you're going to be allowed to do IVF. But if let's say the issue is a low sperm count, you're just wasting your time doing those IUIs when you should have been going to IVF from the very beginning. So these other therapies like IUI, they can be effective. I mean, I've helped patients with IUIs since the beginning of my practice. And there are patients, I have one patient in particular I can think of, she got pregnant in her 23rd IUI, 23rd. She had all the parts that she needs, tubes that are open, sperm that's working, but IVF wasn't acceptable for her. And I'm the most stubborn doctor you can ever find in the entire world right here. And so, I was very lucky to be able to help her in that way. But it just shows that not everyone finds that IVF is acceptable to them. So there certainly are other treatments that they can use.
Doctor, let's talk about success rate. As we think ahead, you talk about the challenges, the emotional toll, and to be prepared. So when we look at, give us a little bit of hope here. Just how successful is IVF? What is the success rate for patients?
I mean, the success rates are better than ever now. If you look at what's happening in the lab, we have a lot of incubators that are better than they were before. The media that we're using in the lab is better. So my embryos are more beautiful today. Like I can say that I can help patients today better than I could help them 10 or 15 years ago because of how things have changed on the lab side. So it is definitely good news. The stats are that, I think it's something like 85% of people will be successful after 3 embryo transfers. So that's quite high. But the issue for some people is just getting that embryo. So, for some people, getting 3 could take 3, 4, 5, 6 cycles. For some people, they're lucky enough to get it in their first cycle. So the general stat on IVF success rates, I think if you look at all age groups, it's probably around 35% live birth rate, which sounds low, but we're dealing with human biology and we're just not really good as humans when it comes to reproduction. But if you have a high quality embryo and if you've done genetic screening and it passes genetic screening just for the chromosome, that's all we usually can test, you're looking at probably a 60 to 65% chance of that embryo working. So that's really good. So over 50% of people who go through IVF who have an embryo like that will be successful.
Tell me a little bit about what you meant by, as humans, we're not terribly good.
Oh, we're so terrible. I mean, if I could wave a wand, I wish that women could ejaculate eggs You heard that here first.
Oh, okay.
And I
Okay.
wish, wouldn't that be amazing that if we could do
Yes,
that? But we cannot.
absolutely.
I wish
Absolutely.
that we ovulated every day. We can't. But we're
Now,
not.
some people may disagree with you on that.
I know, but we're not efficient. I mean, if you look at other animal species, when they ovulate, they usually can conceive and get pregnant. For us, it's about 15% chance per ovulation that a woman can get pregnant. And that's at a young age. And then as you get older, as you're nearing, 40, it's about 5% chance per ovulation. And that has to do with ovarian aging and things associated with that. So we're not efficient. We have chromosomal abnormalities that go up as we get older, miscarriage rates go up. And that's, what I deal with every day in my practice.
Yeah, tell us a little bit more about the impact of maternal age and particularly success rate. And I mean, I know a lot of this has to do with the individual as well, but just statistically, what kind of expectations should people have
Right.
at an older
Yeah.
age?
So the way I frame it is 100% of us will be infertile. That just happens, right? And it's because we eventually run out of eggs until I come up with my invention that reverses ovarian aging one day. I hope that will be a reality.
Okay, we are rooting. We're rooting
For
for
me.
you.
Thank you. But I wish that menopause was reversible and preventable. And, to get on my soapbox, I say if men ran out of sperm, it certainly would have been already. But because it's women, it hasn't happened, and we haven't done enough research. And the research is there to show that it could be done, I think, but we just aren't there yet. But until that day, we know that it just gets harder to get pregnant as we get older because of the changes in the mitochondria and the cells surrounding the eggs. So to give you some statistics, so let's say I have a 40-year-old egg. That egg has about a 20% chance of being genetically normal, 20%. So 80% of embryos, 80% chance an embryo will not be normal. If you go to 42, it's about 15%. At 43, the chance that embryo is going to be normal is about 10%. By 44, it's 4%. At 45, it's 1%. At 46,
Wow.
you're dang lucky to get pregnant. It's probably like maybe 0.09%, something like that. So very low likelihood that a 46-year-old's eggs will turn into a healthy pregnancy. The thing is that if you think about what I just shared with you from 40 to 46, things got really bad really fast. But between 30 and 36, they actually don't turn bad that fast. So oftentimes people feel like they're, hanging off an egg cliff, or they have egg panic at an age they should not. And that is this age of 35. So things don't change that dramatically between 33 and 35. They change dramatically between 40 and 45. But you're right. I think it's individual to that patient. A lot has to do with her genetics, her family history, her environmental exposures, and ultimately age has a lot to do with why women can't get pregnant nowadays, because we, as a society, we're waiting longer. I call jokingly my 35-year-olds teenage pregnancies, because most of my patients are 42. So they come in, they're like, I'm so old. I'm like, no, you're like a teenage pregnancy to me. Don't say that.
Yeah, well, language can be tough,
Yeah.
because I know that at 35, most doctors will call that a geriatric
Right.
Pregnancy, and that's really a tough. It's tough to characterize that way when you do still feel like you're ready to have kids,
Right.
and keep up with them at that. So looking into your crystal ball, you talked about there may be changes in technology, but do you see that access to these treatments will be increased and more available to people, particularly individuals and families who may not have the income to be able to make use and take advantage of these options? That will happen more through changes in our healthcare plans and insurance, or do you think there's also a possibility that the science and innovation may also lead to less costly solutions? I know that's kind of a tough question, but taking out your crystal ball when you solve all of these issues.
So my prediction is that not only is IVF going to be completely free, egg freezing will be completely free, but Americans will be incentivized to do treatment. Very similar to in other countries, because we're dealing with a very obvious population decline. So in order for a society to continue and grow, unless we figure out how to clone people, which isn't happening anytime soon, the only way our society is going to grow is if we have more babies, and our death rate is outpacing our birth rate at a very rapid pace. So it's really important. Currently, absolutely. Yeah. And this is a known fact. It's been going on for years. I've been screaming at the top of my lungs, I want Elon Musk to marry me. Don't tell my husband. I'm just kidding. Because I feel like someone needs to say, Amy, like, just help as many people as you can. As long as you're, alive on this earth, just have babies, and we're going to cover all the costs. Like, that's one of my dreams, like, if that were to come true. But I feel like that is going to be a reality, and sooner than most people think. As far as technology, technology is just hard because of all the regulations and all the all the things that new companies have to go through in order to make breakthrough treatments a reality and clinically available. But I do see that there are going to be ways like IVG, in vitro gametogenesis, where you just take a skin cell and turn into an egg cell. I hope I'll see that day when that can happen. Some people say we're 5 years away. Some people say we're 10. And I have lots of patients that are like, I want to sign up for that study. And I'm like, you just need skin. Like, no one wants your skin. But I think that's a very exciting technology that could totally revolutionize how we take care of patients through fertility treatments.
Well, Dr. Amy, thank you so very much for joining us. Really appreciated your insights. And your patients are very lucky indeed.
Thank you, Barbara, for having me on.
Okay, so to close out today's episode, instead of Lee giving us a fun fact, we're going to take a step back and look at the bigger picture of women's health and the stories behind it. So joining us today is Amy Finkel, an assistant professor of photography at Marist, as well as a photographer and documentary filmmaker, but more importantly, my advisor and professor of about 4 classes now. Her project Getaway is both a gallery exhibition and a photo book that weaves together photography, historical research, and personal narratives to explore gender bias in medicine and highlight women's resilience. Amy, thank you so much for being here with us.
Thank you so much for having me.
Yes, of course. I'd love to begin with talking about how Getaway is such a layered and deeply personal project. What first drew you to want to create something like this?
Sure. Well, I have had, I guess, the misfortune of having and I guess technically have, but I have had 2 surgeries since finding this out, and I'm now fine. But I had endometriosis. My mom had endometriosis. Her mom had endometriosis. Shouldn't have been too hard to find, but I suffered for many, many years with this disease, and was met with a lot of gaslighting by a lot of different doctors, both male and female. It seemed that most of them wanted to imply that the pain that I was going through, my pelvic pain, was in my head, which seemed insane to me. But when you are in a relationship with a doctor where there's a power imbalance, you kind of start trusting what the doctors tell you. And I got to a point where I was so sick, but believing that I was insane, believing what they had said. I got to a point where with one of my doctors, she said the only option for me was to go on a drug called Lupron, which is a chemo drug for prostate cancer. And the teacher in me, the professor in me was like, what on earth are you talking about? This seems insane. So I love research. And so I tried to figure out what on earth was happening with endometriosis and why this seemed to be the last stop on my pelvic pain tour. And Lupron is something that puts a woman into medical menopause. I was in my, I guess, early 30s at that point, which I thought was pretty crazy. It does terrible things to a woman's health, tooth decay, all kinds of different things in addition to menopause. So I finally found an endometriosis specialist when I Dr. Tamir Sechkin, who runs the Endometriosis Foundation of America. And I only found him because he happened to run the Endometriosis Foundation of America with Padma Lakshmi, who is kind of famous. So it's even tough to find these specialists. And I was seeing someone very high up at NYU. So I went there, and no surprise, he did a surgery. You know, it was obvious to him that I had endometriosis. You can't see it in imaging, so MRIs don't catch it, ultrasounds don't catch it. So he did a surgery. You can really only catch it in a laparoscopy. And so he did an excision surgery. There are also several surgeries for it, and most of them are incorrect and don't actually take care of it. So the pain comes back a year later if they do that surgery. So I was just shocked and appalled at the entire situation, and decided that I would start doing my own research beyond endometriosis to see what other, where other sex and gender biases were happening in women's medicine. And I had known about hysteria and Victorian, I had a general concept of what was happening in the Victorian era with women and Freud and somatoform disorders. But then when I started doing the research and looking through NIH data about what kinds of diseases get funded, which ones don't get funded. My disease, at the time I was mostly studying endometriosis at first, sat below something called Marie-Charcot tooth disease. That was getting more funding from the NIH than endometriosis, yet endometriosis affects 1 in 10 women on average. They think it's probably much higher. They don't really know much about endo, but it's been found in fetal autopsies, so they assume it's there when you're born. It's obviously hereditary, though they don't call it that. They call it familial. So I knew there was a lot to pour through. And then when I started looking at some of these other diseases and at healthcare and how much it had changed for women since the Victorian era, for example, which is what my focus is, I kind of couldn't believe how little has changed. I couldn't believe all of the research that I poured over about clinical trials, that women were not even mandated to be part of clinical trials until 1993. And even then, there was not much oversight, so they were not included in those trials even long after that. You think about how many drugs have come out that we all use since 1993. It's a lot of different drugs that were not tested on women at all, and things metabolize very differently in women than they do in their male counterparts. So
yeah, and I assume that as part of your research, you also found that you were not alone.
Oh.
That this is a very common experience. You have to become your own advocate. And not only is a lot of the research missing, but also it's easy to say, become your own advocate. But if you can't even find the resources, who are you advocating to and with? So get back to this concept of your getaway project. Tell us a little bit about what your goal is with this project and what we can expect to see in the exhibit and as part of the photo book.
Sure. Well, Getaway is sort of both testimony and documentation, research documentation, and also these sort of surreal portraits of women and their experiences. Mm. So what we're looking at, some of them are more surreal, some of them are kind of more traditional portraits, though not really all that traditional. But they sit beside, or in a photo book, they would sit next to the testimony from each of these women. They've written their stories. And when I first reached out to them, I found most of the women, now that this project is happening and I've been talking to a lot of women, everyone has a story. And now I have, now it's word of mouth, and I have a lot of different subjects. But I'm a documentary filmmaker first, and I've always been a photographer, but I wanted it to be sort of a hybrid documentary project where I was learning about these women in the stories, and then as a photographer, allowing myself to stray from the narrative that they were telling into a more surreal realm with the portraits. So the truth is there, but not necessarily in what we're seeing. And
Well, we think of healthcare as, science, statistics, kind of numbers. So how did you translate this into an art form? Because I think that's absolutely fascinating.
well, thanks. Yeah. So I started by finding women mostly on Reddit, and everyone had a story. And apparently, you're not allowed to look for research subjects. I've now been chastised and kicked off a number of different boards for being on Reddit. I didn't know that you weren't allowed to do that. I didn't know much about
Interesting.
Reddit. Yes, but these
Interesting.
women I had hundreds of stories pouring in. And
Wow.
I sort of wanted to mirror the experience that I had had, where it was so tough. As you said, though, you have to become your own advocate. That takes a lot of strength, and it takes a lot of doctors. It takes a lot of persistence, which most women who are dealing with endometriosis, that specific disease and a lot of other diseases, do not have. And I did have that to some extent, but I thought, well, now I've encountered all of these women. How do I go out and find them? And some were very far away. So I drove this summer over 60 hours. I drove from here to Southern Illinois, up to Northern Illinois. I drove all the way back. I drove up to Maine. I thought it mirrored the kind of experience that a lot of these women were having anyway. They wanted to feel seen and heard. And I am very much with them in this. I think it helped that I was an ally and that I understood what they had been going through, regardless of what the story was. There are a lot of reproductive disorder stories in there, but there are also a lot of stories of women being abused by doctors. So what I did for the creative process is not only am I printing using Victorian era printing
Oh,
processes.
interesting. Okay.
Yeah, so everything kind of looks, even though there's modern imagery in it, it kind of looks as though it's, if it's printed in albumin, that was a process that was invented in 1850. I wanted to do that. There's a lot of calotype in there, platinum, palladium, various processes. Albumin is something that uses egg whites. Albumin is egg whites, so that obviously ties into fertility. So it's
I did learn about this in Amy's class.
yes, so it's a little more on the nose in terms of concept. But a lot of these processes were invented, in the 1850s through, late 1800s. And you look at how many technical developments there have been with cameras, just, photographic technology since the 1850s, or something even like the speculum. The speculum that we all encounter in our gynecological exams is the same exact design as the speculum that was invented in 1850 by a kind of problematic fellow. So was cyanotype, so was albumin. I think I really wanted to show that while there has been quite a lot of progress, and particularly with something like endometriosis over the last couple of years, because it's become a little bit buzzy, it's a little bit hip right now.
Sure, we have some celebrities who've chronicled their experiences, and that's very helpful. As much as we can have, even people like yourself that is using their art and their talents and their professionalism to explain and to articulate what this is makes a huge difference.
Yeah. So I really wanted it to be the women's stories. I really wanted it to be, and their exploration of the stories. I had never done this before, but again, as a documentary filmmaker, I'm always looking for truth. And what I thought I would do is have it be a collaboration with these women so that they very much felt involved. And I asked them, I kind of took them back to English class I never taught English, but English class in high school, and said, think in visual metaphor. When you first learned about writing poetry, try to imagine what this experience might look like visually to you. And I keep joking about how the project is a lot of angry women, which it is, understandably. But it's I got a lot of responses like, well, I can imagine myself with a hatchet. Can we go to a rage room? Can we go to an axe throwing? So I said, well, absolutely, you can have an axe. But let's talk about how that might look. And let's really think about what the essence is, like what are the feelings? And so sort of like therapy sessions with them. So I meet them over Zoom first, and then I went and just found them, which as a documentary filmmaker didn't really feel all that strange. I keep hearing like, but weren't you going to get killed? You were meeting a woman with an axe in the middle of nowhere in Illinois. It was, of course, it all worked out. And I had a woman in Maine whose story is about, she was an active duty Marine. She had horror stories about being abused by a doctor when she was an active duty Marine. But she really wanted to be a witch, in sort of like a vampiress / witch was what she had seen, a Victorian era, someone haunting towns, that she wanted to wear a white dress and be in the woods. And so I said, well, you know what, let's make that happen. Let's do the thing that you see in your head. And I had sent one of those pictures to, I think you probably have seen that one that I sent to Cassidy. Yeah. But that was her story. And then that one that I sent you, I think, was printed with platinum palladium, where it's a fine art process where you're painting onto, I don't know, with a lot of different chemicals, but painting onto a piece of watercolor paper, and then, mixing digital and analog processes, which all felt very conceptually on the mark to me. Yeah.
Amy, just before we let you go, thank you so much again for joining us. But where can folks find more information about Project Getaway?
Well, there will be a website. This is another, I'm probably about a year away from finishing the project because I have about 11 portraits to date. And I've done quite a lot of research, but I'm hoping to get between 20 and 30. And I have a feeling this will probably be an ongoing project in my life because 20 or 30 does not do it justice. There are so many stories.
From a very personal standpoint, final question here. What is your message to women as an advocate for women's health and for someone who has been so personally been affected by a women's health issue? What is your message to them?
I would say the number one would be trust yourself. You can always trust yourself. And
so important.
So important. And I think I have a lot of women in the project who have been sexually assaulted by doctors, who didn't trust themselves, who thought, well, he's a doctor. And, if we just were able to trust ourselves and use our voices to say, no, there's something that's not right here. I know I have pelvic pain, or I know that in one of my subjects, she went to a gynecologist about having painful intercourse. I hope it's okay to say that on here. And it turned out she had bladder cancer, but that was 2 years later after doctors telling her, well, she just needed more foreplay. So, and she was in her late 60s, so trust yourself. You know your body better than anyone else. And it probably is this bias that is coming in that was deeply rooted in, early Greece, but especially in the Victorian era that is still coming through today. And maybe together we can affect change.
Dr. Amy Finkel, Assistant Professor of Photography here at Marist. We're so grateful to have you here today. And Marist is very lucky to have you here as an educator. Thank you again.
Thank you so much for having me.
That'll do it for Poll Hub this week. Poll Hub is produced by the Marist Poll at Marist University in Poughkeepsie, New York.
Mary Griffith is our executive producer.
Casey Schaff is our production supervisor.
The Poll Hub team includes AJ Gambino, Tommy Rogers, Cassie Connors, Sylvia Weiser, and Molly Goodger.
If you enjoy Poll Hub, consider telling a friend about us.
If you'd like to learn more about polling and survey science, check out the Marist Poll Academy, our free online learning portal accessible from our website.
Remember, you can always tell your smart speaker to play Poll Hub, and with any luck, it'll cooperate.
Finally, wherever you listen to Poll Hub, there is a subscribe button. Click it, and the latest episode will be ready for you in your podcasting app as soon as it's released.
We'll see you next time.